on it now, and we'll go from here. Thanks, Sandi.
Thanks, Alastair. Thank you so much for the kind words. And I don't know if everybody can see me. I hope they can, and I hope they can see the presentation as well. Please write in the chat function if you can't. I think I'll start. First of all, I'd like to thank Muscular Dystrophy in New South Wales for inviting me here today to share with you some of the new exciting developments for myotonic muscular dystrophy that are emerging and are on the horizon. And as a clinician, having worked with children and families affected by this condition, in my role as a paediatric neurologist, I know firsthand how engaged the myotonic dystrophy community is and how active the affected individuals and families are in advocating for clinical trial and best practice development in the space. So I'm very excited to share some of the new advances in this sphere with you today and look forward to a lively discussion afterwards. So why this talk and why now? I think in the not too distant past, individuals working in research and those managing patients in clinical practice often worked in silos. The work done within research at the basic science level, so basically in the laboratory, filtered down very slowly to the patient with very few numbers of clinical trials and lack of implementation into healthcare. And management was really based on creating consensus standards of care to optimize and standardize best practice. But now what we have is that this process or life cycle of translating research into findings to improve clinical care, it's accelerating, and we can't really afford to work in silos, otherwise we'll just get left behind. What we need is basically our patients and families at the center of what we do. Really, you are the most important stakeholders to drive the direction of research and contribute to the creation, implementation of research from its roots in basic science, right the way through to clinical trials and into the clinical space. And what we're trying to do is bring research and clinical practice together, basically with the affected individuals and their families as the glue holding everything together. So that's why this talk and why now. So in the spirit of this, I think I have around 30 minutes or so, maybe a bit shorter. I want to give a lot of time for chat and discussion at the end. And what I essentially want to do is to give you a research map of myotonic dystrophy in 2022, where we are now and where we hope to go in the next few decades. In terms of objectives, firstly, I'm hoping to give you a brief overview of the clinical presentation of myotonic dystrophy and the genetics. Many of you will already be very familiar, very well versed with these concepts, but as many of the up and coming therapeutic strategies are targeted to specific signs and symptoms, and interventions are based mainly on manipulating the genetics of myotonic dystrophy, I think it's good to all be on the same page when it comes to these fundamentals. Then I'm hoping to go into the gaps within the clinical and scientific sphere as I see them. But I'm hoping in our discussion to also get a feel of what you as the audience, the stakeholders, think are the burning issues and the barriers within research and clinical practice for myotonic dystrophy. I think much of the excitement is about current and emergent clinical trials for myotonic dystrophy. And what I hope to do is firstly talk about what a clinical trial is and give a little information about clinical trial readiness for interested patients and families, and then go through a little bit about the drug development pipeline, hopefully to get you excited about the future. I'm hopeful that if I can keep your attention through to the end, that I'll give you an insight into the interconnectedness of myotonic dystrophy research and how this may influence and hopefully improve health outcomes for affected individuals and their families. Okay, so let's get started. So in brief, what is myotonic dystrophy? And as I said, I know I'm preaching to the people who know the most about this condition, but let's all get on the same page before we start. Myotonic dystrophy is the leading cause of muscular dystrophy in adults. And it's what I consider a spectrum disorder that can affect all age groups, from the newborn right through to adults. The hallmark of myotonic dystrophy is muscle wasting and myotonia, that is delayed relaxation of muscle after voluntary contraction. The condition is an umbrella term for two quite distinctive presentations, DM1 and DM2. DM1, which usually begins in the muscles of the hands, feet, neck, or face. It slowly progresses to involve other muscle groups, including the heart. Myotonia tends to be more prominent in DM1 compared to DM2. In the congenital and severest form of DM1, newborns present with floppiness, respiratory failure, feeding difficulties, and foot deformities. And we often get called into the neonatal intensive care unit as paediatric neurologists to come and see these babies and help diagnose them. On the other hand, DM2 it's generally milder than DM1. I hesitate to say that because this condition as a whole entity, it's not mild in any way, shape, or form, but it's milder than perhaps the congenital form of DM1, with perhaps fewer affected individuals with DM2 requiring assistive devices compared to those with DM1. DM2 preferentially affects muscles closer to or on the torso, including the neck flexors, hip flexors, and hip extensors. And muscle pain is a really prominent feature of DM2. Heart issues, which while still potentially fatal, are less common and severe in DM2 compared to DM1. Symptoms onset is also different. It's early to late adulthood. Severe congenital myotonic dystrophy is rarer in DM2 when compared to DM1 as well. So I just want to get you a breath that this is a very what we call heterogeneous disease. So not only do you have this variability between the two forms of myotonic dystrophy, but there's also considerable variability in how individuals are affected, even individuals within the same family. The slide that I've just presented here just attests to how this condition is truly a multisystemic disease, which can affect so many biological processes within the body, from cognitive function, the biggie, which is heart conduction abnormalities that give rise to heart rhythm problems or arrhythmias, right through to the effects on your immune system, your endocrine system, and your reproductive system. The complexity of myotonic dystrophy is coming through here. And the fact that clinical management, despite any therapeutic intervention that's currently here or on the horizon, it will always be based on a foundation of coordinated, personalized medicine and multidisciplinary care, really, so that all these elements can be supported for the individual. Lots of families come to me and say, oh, we'll get this medication and my child will be fine and they won't have to come to clinic. That won't be the case. If whatever therapy is out there, we have to optimize with a foundation of supportive care, and that's often in a multidisciplinary team environment. So as we all know, myotonic dystrophy is a genetic condition and it's inherited in an autosomal dominant manner, meaning that each child of an affected individual has a 50% chance of inheriting the disease. The affected area is different between DM1 and DM2 genetically, but essentially it's based on an area called satellite DNA. And these are basically sections of DNA where the building blocks are represented or repeated in groups of 3. These areas don't necessarily code for any protein, but are like buffering pieces of your genetic code. We don't know exactly what they do. Here is an example on the slide of the variant that causes DM1, which is on the DMPK gene on chromosome 19. And all of us have varying numbers of this 3-block repeat within this area. But once you go beyond a certain threshold number, you start manifesting symptoms of DM1. Between 5 and 37 repeats is considered normal. Between 38 and 49 repeats is considered pre-mutation. And although you're not going to be manifesting symptoms necessarily, there is, children can have further repeat expansion as their cells divide, and they can become symptomatic. Greater than 50 repeats you're almost invariably symptomatic, with some noted exceptions, and longer repeats are usually associated with earlier onset and more severe disease. In a process known as anticipation, parents who have over about 37 repeats or so have a particularly unstable area within that satellite zone, and they can accumulate and pass on even more 3-block repeats to their children. So I just wanted to give you a glimpse of the complexities of the genetics, and because basically the therapeutics are often based on modulating these genetics. Myotonic dystrophy type 2, it's fairly similar. It's caused by expansion of a repeat block of 4 DNA building blocks in the beautifully named zinc finger protein 9 gene. A little complicated, but important to understand before we delve into what's new and what's on the horizon. So this is where I pause, and I hope open the session a little bit on to you, the audience on the floor. Currently, there are no approved treatments or cure for myotonic dystrophy, and our management approach is based on supportive care and alleviation of symptoms. And I must say that we shouldn't undervalue that. We've made really good strides forward within this space with more proactive clinical genetic screening, guidance and anticipation of future care needs, and development of best care guidelines. But we can always go forward. As a clinician, I have my own ideas, as I said, of where the gaps in terms of care and research are, but I would be interested to know from you where and why you feel the barriers are to moving forwards and developing strategies that can further improve the condition for individuals affected by the condition. I'm not going to put anybody on the spot, so don't worry. I don't know if this will work virtually, but if anyone wants to just comment in the chat function, we can look and discuss this as we go along, or perhaps at the end. To me, there are some barriers that I come across in myotonic dystrophy, both in terms of research and clinical management. Here are just a few. It's a complex disease with considerable variability in how it affects people. A huge spectrum of ages and progression. What works in an adult may not work in the newborn. Do we really understand the genetic changes that lead to the disruption of body or biological processes? Yes, we've got an understanding of the genetics. The genetics is complicated, but do we know how that affects your heart, affects your muscle, affects your brain, affects your pancreas in different sites? Not necessarily. We need to know what those biological processes are so that we can reveal more therapeutic targets and modulate them. Do we understand the natural history of the disease? And when I say natural history, do we know really how it evolves? For example, in the congenital form, where you have it as a baby, do we know what life is going to look like? Because only when we know what untreated myotonic dystrophy looks like, do we know when we have therapeutic intervention, whether it's going to be effective or not. It's really important to understand the natural history of any condition before we introduce therapeutics into the mixture. How do we measure if our therapeutics are working? Do we have really good outcome measures? And not outcome measures designed by clinicians, but outcome measures that are meaningful to you as the community, that will help in terms of assessing quality of life and everyday function. How do we develop those? And how do we recruit and enroll individuals safely onto clinical trials? So for me, those are just some broad sweeps, but I would love to know from your side, because I know lots of people have ideas where you feel the barriers are. So now going on from the gap into what's happening for myotonic dystrophy currently in the therapeutic sphere. I want to really give you a snapshot of the drug development pipeline for myotonic dystrophy. As of this year, and I find this really exciting, I've been a neurologist for 7-8 years, but working in this sphere for over a decade. And really, there has been nothing for so long. And now we've got close to 24 drug developments occurring in this space. And five of these, the ones at the top, if you can see, are already in clinical trials for affected individuals. So it's such an exciting time to be in this research sphere. As you can see from the slide, there's a whole process to drug development, and it takes time, sometimes decades, for drugs, once conceived, to enter preclinical, and that's often animal or cell line testing, to see if there's any mileage in taking them into trials in animals and in humans. And a lot of you will know about clinical trials, but not everybody does. What is a clinical trial? It's a set of tests within drug development and research that show us how safe and effective treatment or intervention is. They can only be conducted in humans once there is some evidence of safety in the lab and in animal models. And trials are the processes by which the drug becomes available and approved onto the market. And there are three main phases of a clinical trial in humans, phase 1 to 3. Phase 1 trials are the earliest phases, and phase 3 are the later phase trials. And phase 1 is basically often small. These are about finding the best dose for the treatment and what the side effects may be. Phase 2 trials are about checking that best dose in a large number of patients and finding more about the safety of the drug, but also some knowledge about how the treatment is working and if it's working. And phase 3 occurs in a large cohort of people, and it always, or not always, sorry, usually compares the treatment to the standard way of managing the condition or to a dummy medication or dummy procedure, and that's called a placebo. Phase 4 is not illuminated in this slide, but it's where you basically gather the long-term side effects and efficacy parameters of a trial. So that gives you a little bit about the life cycles, and that's important to understand if you are invited to attend or to enroll into phase 1, 2, or 3 trial. They often have slightly different purposes. Right, I'm not going to go into all the upcoming trials, but I want to give you a brief insight into basically 3 medications that are within phase 3 trials. So that's the closest to kind of that approval in the market. And they've gone through phase 1 and phase 2 parameters. And they're thought to hold a lot of promise for the future of myotonic dystrophy. All 3 of these medications have been repurposed, and that means they've already been used to treat other conditions that have been adapted to now treat myotonic dystrophy. They're not cures, but they're disease-modifying agents, or thought to be disease-modifying agents, i.e. they act on the biological processes and change the way that the disease process works. Now, given that drug repurposing candidates have already demonstrated safety in humans for other purposes, they can be tested much more quickly and at less cost and at lower risk than entirely new therapeutics, which explains perhaps why they're closest to reaching market authorization. And here we have, I hope you don't ask me to pronounce these, but there's tidaglosib, there's mexiletine, and there's metformin. And these appear the therapies with the most potential. And these are all agents that can be taken by mouth, and they're called small molecule oral therapies. We'll go through each one at a time. Mexiletine is a medication used to reduce or prevent myotonia. And remember, that's that improvement of that relaxation agent when your muscles are voluntarily contracted. And its effect is thought to be through blocking channels involved in the contraction and relaxation of your muscles. As I said, it's an oral agent, and it's been trialed in adults and found to improve the hand grip myotonia, so allow your hand to relax more. And it's also thought to improve your muscle strength with hand grip. It's found to be safe over a 9-year follow-up period. And now we've got a phase 3 trial in children and adolescents with DM1 to test it out. So that shows it's probably the one that's most advanced in terms of trial and the most promise. Metformin, many of the adults in the room will know of this drug, and it's a well-known diabetes drug that improves insulin resistance. In myotonic dystrophy, the drug has been used to act on that middle messenger between your DNA code and the protein that it produces. And this code is called RNA. In myotonic dystrophy, in brief, there's a disruption in the way that middle messenger, the RNA, is chopped up and stitched back together. And basically what metformin does is it's used to correct that dysregulated process. And in terms of the where it's at, there's been a completed phase 2 clinical trial assessing oral metformin, and it's revealed significant improvements in mobility and gait parameters. And phase 3 studies are now ongoing. I think a lot of the centers are in the US. Lastly, there is tidaglutide. It's again an oral agent, and it was formerly used in Alzheimer's disease. It actually didn't do very well in Alzheimer's disease, and they stopped the trial. It's thought to work on multiple pathways and improve brain and muscle function. And currently a phase 3 trial is underway. One of the centers is Sydney Children's Hospital here in Randwick, trialing this out in children and adolescents with DM1. So it's exciting to see a lot of these adult trials coming through to the pediatric sphere now. So we know that for any outcomes to be optimized, affected individuals should continue to be managed within the multidisciplinary team. And I know I keep banging on about this, but it's just so fundamental. They should all have access to that standardized access to best care. At the moment, small oral molecule space seems to be the most active in terms of therapeutics, but are we heading to a time where we can think about a really individualized approach to reducing the disease burden through advanced genetic therapeutics? Potentially, yes. In clinic, time and time again, I get asked about the holy grail of advanced therapeutics, and that's basically gene therapy for myotonic dystrophy and how close we are to the prospect of it. Under the umbrella of genetic therapies, we have RNA-based therapies, such as what we call oligonucleotides. The promise of an oligonucleotide-based drugs is starting to be realized, and there's a lot of activity in this sphere. And outside myotonic dystrophy, at least 10 of these drugs have been approved for clinical use across the muscular dystrophy. So it's a really exciting sphere of research. In DM1, the focus has been on using these therapies to eat up or reduce the length of abnormally long RNA messengers. So remember, the DNA, you're going to have long, lots of repeats. So your DNA code is going to be too long. That means your messenger code is going to be too long. And when your messenger code is too long, these abnormal messengers, they accumulate in your cells. They don't help the function of the cell. They're actually toxic to the cell. So you want to block that long code, or you want to eat up that code. So what these oligonucleotides do is they work to either prevent these long messenger RNAs from occurring or break these long messenger RNAs down so they don't produce toxicity to your cell. In myotonic dystrophy, it's quite difficult to get these oligonucleotides into the cells that you need it to get into. For example, your muscles and the other systems in the body that myotonic dystrophy affects. And there are trials looking at ways to increase potency. So oligonucleotides, exciting myotonic dystrophy, but not quite there yet. We need to really focus on getting them to be more efficacious. Now, gene therapies, lots of people are talking about gene therapies. They seem ideal to tackle the multisystemic nature of myotonic dystrophy. Gene therapies are essentially where you have a virus that doesn't cause disease. It could be a virus, it could be another delivering molecule, but I'll choose viruses as an example. And they act like envelopes to carry a working gene, or they carry a pair of genetic scissors to help cut out the abnormally expanded area within that satellite region of your DNA, and allows your body's own machinery to stitch up the DNA code that doesn't contain that abnormal and long repeat. The virus particles are either delivered systemically through infusion into your vein or directly into the muscle. These therapeutics are within the preclinical phase of development.
Sandi, I have a message that will be closing the room in about 5 minutes. So,
5 minutes, no problem.
Yep,
I might just rush through then a little bit. So they are in the preclinical phase of development. They're not quite there yet, but it's an exciting space to watch. So how do we get ready for clinical trials? I think the way medicine is going and into the future, access to therapies will be expedited, and they form the bedrock of management for increasing numbers of affected individuals. And you might want to ask questions. This is not an exhaustive list, but basically, what's the purpose of the clinical trial? What does a clinical trial involve, and how are these tests given? What's likely to happen to me with this new research treatment, and what's likely to happen if I don't undertake this research treatment? How does the clinical trial affect my daily life? What side effects can I expect? How long will it last? Some of these trials last years from the kind of follow-up phase as well. It's not a small endeavor. And will the clinical trial require extra time on my part? Will I have to be hospitalized? If so, for how long? And if I withdraw, will my care be affected? And if I say yes, will I automatically need to access the trial? Why would you want to go on a trial? Well, there are potential benefits. You may be able to receive a new treatment before it's widely available to the public. It may improve your health and quality of life. You may be able to get very close surveillance during and after clinical trial cessation, which improves your overall outcomes. And obviously for us, it provides researchers with information that helps come up with better treatments, and you can help to save and improve lives. But there are side effects. Often we don't know the long-term side effects, even though we've got some of that phase 1, phase 2 data. There could be harms to overall health. You may be asked to stop medications that were working for you, and you may not be able to take those medications up for the duration of the trial. And if you go onto those phase 3 trials, you may be receiving a dummy drug or an intervention. You may not be assigned to receive the actual intervention itself. And it may stop you from accessing other interventions or trials in the future. I don't know if I have time for this, but it's basically, a lot of people ask me about stem cells. I think if people are interested in stem cell therapy, they can just, I'm very happy to receive questions and emails, but a lot of people, there's a lot of it out there about stem cell therapy. But again, what I want to put out there is that stem cell therapy is in a very experimental phase of life within the clinical trial sphere. But please email me if anybody wants to know more about stem cells and myotonic dystrophy. I think Robin has gone through the role of data registry, so I won't go into that. I hope we have time for questions. I'm sorry, this is such a gallop through. I must have talked very slowly. Please share with me your comments. I want to know from you what you feel the barriers are, or what you find exciting within this sphere. And if you want any patient resources, these are some that I have happened to find very helpful. Clinicaltrials.gov, excellent resource for any of the clinical trials that are up and coming. So, Alastair, I might just leave time for questions if that's okay.
Right. I think they're about to close the breakout room on us. Thank you very much, Sandi. That was an excellent run through. And I think it's given us all plenty to think about. So